with ADHD, and she said they end up with sleep problems. So I'm gonna counteract that immediately with a comment, and that is that about 85% of kids with ADHD have sleep problems, whether they're on medicine or not. And often it's not something that we did a good job asking about early on, which is one of the reasons we always use a sleep questionnaire, by the way, and you're welcome to do that in Chattis. There's a number of good ones. But because there's a couple reasons that's really important. One of the reasons is that that lack of sleep can look a lot like ADHD. In fact, it's one of the things in the differential diagnosis of ADHD, because lack of sleep causes inattentiveness and often irritability and restlessness, which sounds suspiciously like the symptoms of ADHD, right? But it's also that there are various things about ADHD that cause sleep problems. So let's just break that out a little bit. But it's worth asking about what it was true before medicine, so you don't blame it all on medication as the reason for the sleep problem. So what are some of the things you've noticed that make it a problem for kids with ADHD and sleep? What are you noticing? Is it onset? Is it waking up in the night? Is it waking up too early? What are you experiencing?
Primarily, there's difficulty going to sleep at night. Or having a very short sleep cycle, just like their parents.
Just like their parents. Good point. So trouble falling asleep, and then a short sleep cycle, meaning they're waking up early in the morning?
Yes.
Yes. So both things. And how did you happen to know that their parents have the same trouble?
Because I always ask.
Good for you. That's really good. It's helpful because oftentimes parents aren't complaining about sleep when the parent themselves are sleeping fine, right? They don't know the kid's up. So they're not complaining. So the ones who are complaining, it's worth saying, so how come you know he's up at 3 o'clock in the morning? And they say, oh, well, because I never sleep past 3 o'clock in the morning myself. So those are still problems for kids that need to be solved. And there's some really important pieces to help with this, with ADHD or not with ADHD. And I'll actually go to one of my intervention slides here so that you can see it. Let me see if I can pull it up for you. Sleep hygiene. Let's talk about sleep hygiene for a minute, because it's funny that the School of Public Health here at Johns Hopkins used to be called the Johns Hopkins School of Public Health and Hygiene, and I really liked it when it was called that, because hygiene really has to do with whether we are doing the preventive things for people's well-being. And one of the preventive things is like wash your hands, and have toilets and stuff like that. But when it comes to sleep, there's some things we know that help kids sleep better. So one of them is a cool, dark room used mainly for sleeping. Now, how many people do you know who have kids who have a room that's used mainly for sleeping? Well, practically nobody, right? Because they're always playing video games in there, or they've got a lot of toys in there and so forth. But making it more like that can be helpful. And then, number 2, a regular schedule 7 days a week. And how many of our patients have a regular schedule 7 days a week? Also not so often. What's the main defect in what happens with the 7 days a week rule?
Sleeping on the weekend.
Yeah, they're staying up late on the weekends, and then they sleep in the morning. And the older you are, the harder that is on your melatonin secretion. And I can flip back to that slide in a minute. But disturbing that is really a problem. And there's some kids who have a very slippery circadian rhythm, where if they are off by as much as 1 hour on the weekend, that it messes up their circadian rhythm. But most people are not like that. So for most children, if they don't deviate by more than an hour, from the bedtime on weekdays to the bedtime on weekends, they'll be okay. But this is actually good advice then. When you're negotiating about sleep time with kids, you say, well, you really should sleep go to bed the same time every night. And they say, oh, Dr. Howard, what do you mean? I say, well, how about 1 hour difference? And then they'll go along with that. So for most children, that will then work. But the other part of it's also important, and that is not sleeping in the morning, because that also changes a couple different things. It changes the sleep cycle, and in adolescence, it changes the time of melatonin secretion. So adolescence, the endogenous melatonin secretion in adolescence shifts to a later time, meaning they're not as tired at the regular bedtime. And if they're allowed to go to bed later and sleep in longer, it actually makes it even worse, where they have less drive to fall asleep at the regular bedtime. So helping to understand that can be really good. Trying to get kids to go to bed closer to a regular schedule is hard, but if the people are complaining, and often the kid is complaining too, you can often convince them to get it closer to 7 days a week. Then the third one on the list here is avoiding vigorous exercise within 2 hours of bedtime. So how's that working with your patients?
Most of our patients, that's not an issue.
They're not, yeah, because they're playing video games. We'll get to that.
Exactly, they're not exercising at all.
Right, we'll get to that in a minute. But there is a group of kids who are playing sports that run late into the night. I think winter indoor basketball and indoor soccer are some of the worst ones, where the games start at 8 o'clock and the kids coming home at 9:30 and they're expected to go to bed and they really can't. So hopefully that's not their whole 12-month year, but for certain seasons it can be particularly a problem. And then watching out for stimulants at bedtime. Now, we're going to talk about medication stimulants in just a second, but we've got to find out whether they're getting caffeine or tea, which has theophylline in it, which is also a stimulant, or nicotine, i.e. smoking cigarettes or smoking electronic cigarettes, and then medications, including the stimulants that we're prescribing, if they are continuing close to bedtime. So are any of you finding certain medications to be harder on making kids with ADHD have trouble falling asleep than others? So the main culprit, actually, is Vyvanse. Because Vyvanse can have a very long term of action. It also is associated with more irritability, but there are many more sleep problems with Vyvanse. So if you've got a kid on Vyvanse, even if they're doing well during the day, if they're having a lot of trouble going to sleep, that's something to think about. And I'll come back to other medicines in a minute. And then having a good bedtime routine that makes the child feel safe. Because one of the things that can keep you awake instead of being able to go to sleep is if you're upset about stuff. And that means if there's been arguing in the household or there's been aggressive media. It could be television. It's even worse if it's video games. It postpones sleep onset and causes more night waking as well. So instead, reading a book is a really good idea, and having a nice, pleasant talk with your parent it's never too late to have the parent drop in at bedtime to help soothe the child. So no media in the bedroom is really the most important thing, and we've got a lot to work on there because I think it's 25% of 3-year-olds have a television in their bedroom. And now with portable media, like tablets, people are taking cell phones and tablets into their bedroom. So trying to get them to leave those things locked on their charger in the parent's bedroom can be really an essential part of helping kids fall asleep. And then finally, we've got to remember that sleep associations are not just for babies. Sleep associations can be a problem for older kids too. Sometimes it's the TV on. Sometimes it's a sleep association with music, which they say, but I can't fall asleep without the music. And the fact is, yeah, they can't, but that's why they're waking up too, because when they wake up, the music isn't there anymore, and that's what a sleep association is. It's that you can't reproduce it, so that you can't go back to sleep. So those are all sleep hygiene comments I can make. And we'll talk also about some sleep therapy components, but let's talk a little bit more about medication and ADHD. So it turns out that there are some kids with ADHD who go to bed better with stimulants in their system. So after all I just said, some of them are too hyperactive to fall asleep. And for them, a later evening dose of medication can be helpful, often at a lower dose than what they take during the day. So let's say they're on 54 of Concerta, maybe 5 milligrams of methylphenidate closer to bedtime may help that kid settle down to go to sleep. I quite often end up, even with all the sleep hygiene advice, using something else for sleep. What do you guys prescribe? Okay, melatonin or clonidine. And I agree with you. Those are the two main ones. It's really important to recognize. I'm going to find a slide here in a minute that has it. Yeah, here we go. So this is a slide about primary insomnia, which is not what we're talking about with ADHD in general. But what you'll see here is these are the evidence-based medicines for sleep in children. So clonidine, melatonin, and an amino acid called L-theanine will help with the sleep onset latency. That means how long it takes to actually fall asleep, as well as total sleep duration. And the ones that are not recommended and actually don't help are Ambien, Lunesta, or the equivalent Zolpidem, and Esopiclone, I guess that's how you say it, and interestingly enough, guanfacine also. So it's important to recognize that. So when you use melatonin, there are two forms of melatonin. There's melatonin CR, controlled release, and there's melatonin SL, sublingual. And it's the CR that has to be given an hour before bedtime to be effective, but the SL does not. And so I've actually switched over to using the SL and also making an SL available to them by their bed. And that can be really helpful for those kids that you're telling me are waking up in the very early morning hours and feel like they can't go back to sleep. So these are the 3 a.m., 4 a.m. wakers where they actually have not gotten enough sleep, but they're waking up in the middle of the night. The CR melatonin really doesn't help that very much, but an SL at that time can be helpful. And a decent guidance on milligrams is anywhere from 1 milligram to 10 milligrams, but I recommend that you start at the lower end. And there's some data now that a lower dose of melatonin may actually work better than a higher dose. And you've got to remember that melatonin also lowers the seizure threshold. So if you do have a kid with a seizure predisposition, that's something you have to warn them about. And of course, if they start getting seizures, you want to stop it. But that's a kind of medication that you can, according to our current data, is probably okay to use. And clonidine is another one. Now, clonidine only works for 3 hours, but it does help you get tired. It doesn't work immediately. So that's another one that you want to give in advance of bedtime, like perhaps by an hour, so that when they get that sinker and they're ready to go to sleep, it will help them. So there's some new medicines on the horizon for ADHD that actually work overnight and help with morning waking. And I was just talking to the rep for one of these about how that actually might be helpful for some of these sleep problems, but it's not available yet. So
I guess I'm curious about melatonin, and if we give it to them in the middle of the night, are we, like, I just always worry about completely disrupting the brain's melatonin production.
Yes, we probably are, but that's probably why they're having trouble in the first place. So that's why the SL would be a better one to use than a CR if they're having that kind of trouble. Now, the other thing that we've got to remember is that it may be that you can use it for a period of 2 or 3 or 4 weeks and get them to resettle, and then you don't have to continue it. So oftentimes what happened is it's become a kind of a habit for them to wake up in the night, particularly if they get up and eat. So one of the things to keep in mind with kids with ADHD is sometimes they didn't, especially in puberty, they may not have gotten enough calories during the day. So when they wake up, they're hungry. So they may wake up because they're hungry. That was Dr. Sterner saying that. So making sure that they get a snack before they go to bed, something healthy, not with caffeine in it, and maybe even have some food by the bed so that if they wake up hungry, they can eat without getting up. Because once you get up and go down to the kitchen, then you're fully awake, and that's really very poisonous for sleeping.
It's good to find out what they're already using, because there's one or a bunch of medicines that you wouldn't want them to use that are commonly used. One of them is that one called Benadryl, and that really is one that you want to make sure they're never using, because first, a lack of efficacy, but second, it causes inattention for the first 6 hours of the next day, which is what you're trying to work on. So that comes up sometimes that the parents are doing it. Some pediatricians are still using Benadryl,
I know,
too,
it's amazing,
which is really a bad idea.
Very bad idea. So I want to mention a couple other things that are on this slide about primary insomnia. So I told you that I don't think that the kid you're describing with ADHD has primary insomnia. Keep in mind that that as many as 30% of kids with ADHD also have anxiety or depression, and that anxiety is a reason for having trouble falling asleep. And many kids with ADHD also have a learning disability, and having a learning disability but caring about your schoolwork can keep you up at bedtime as well. So those things would fall in the category of reducing daytime stress, if possible. If there's some things that you can do to make sure that this kid is properly accommodated and has the right kind of supports in school, that can be helpful. Be sure, again, ask about caffeine, nicotine, and also alcohol. In older kids, alcohol is not good for your sleep as well. But for real insomnia, some of the treatment includes desensitizing to the bed. So let's talk about that for a minute. So sometimes a kid has got such bad experiences lying in bed worrying that they go in their bedroom and they begin worrying right away. So some of the things that can help that is to basically break up the habit by, for example, moving the furniture around and taking the clock and turning it around. If they have to have a clock in the room at all to wake up, turn it around so they can't look at the numbers on it, so they don't know how long they're lying there in bed. Make sure they have some kind of comfortable routine. It might include something relaxing, like a hot bath or meditation. And then this is the piece of insomnia treatment that I want to make sure you understand, and that is, if a child is getting anxious and lying in the bed and worrying about falling asleep, if they should only stay in bed awake for 10 minutes. And if they're not asleep in 10 minutes, they should get up, stay up for an hour, and then go back to sleep. Now, when you first start working on this, they're going to be short on sleep, but that's actually the point. There's two parts to the way this works. One is they don't spend as much time being anxious in the bed. And the second one is by postponing the bedtime, their sleep drive increases. So the other part of this, the other caveat is, though, that they have to do this 7 days a week, and they have to get up at the appropriate time every day. So in other words, they can't sleep in, as I mentioned before, because that changes their circadian rhythm. So this is actually a really good way of treating bedtime resistance in younger kids also. So if you've got a younger kid who struggles against the parent for like an hour and a half before they can get them into bed, start the bedtime at the time that they're finally falling asleep. Keep the morning wake up appropriate for the number of hours they need, 7 days a week, and then once they're in the bed and falling asleep within 10 minutes, then you start moving the bedtime back about 15 minutes per day until it's at the appropriate bedtime. This is really, really valuable. Who is right here? And you say, no naps. Okay, we all know. Don't have anybody who's over age 4 taking a nap, right? But what we sometimes forget is that teenagers come home from school, there's nobody there, and if they're not just going immediately into playing video games, they may take a nap, which definitely messes up their circadian rhythm and reduces the sleep drive, making it much harder for them to go to sleep. So it's really important to check on that in every single case. Anything?
I would just ask about, I I think that we see a lot of the majority of our adolescent patients who are, school, sometimes they are getting up. They have to be on the bus at 6 in the morning, and it feels like it's virtually impossible to have them be able to get their schoolwork done if they're doing a sport, get to bed at a reasonable hour to get enough sleep, and then they build a sleep deficit. And for those kids who have anxiety and depression, it just becomes this really downward spiral that feels really hard to disrupt.
You are exactly right. So here's what you're up against. You're up against the fact that children need, between 12 and 18-year-olds, need 8.5 to 9.5 hours of sleep. But that is just not happening. Here is the data on teenagers. So 12th graders, 75% of 12th graders get insufficient sleep, less than 8 hours. And 3%, only 3% get 9 hours or more. And this happens gradually starting around age 10. Between age 10 and age 20, there is a delay, an increasing deficit of 2 hours for girls and 3 hours for boys, roughly 12 to 18 minutes later each year. And the result of this is that 59% of teens wake up feeling unrefreshed at least a few times a week. And 17% say they have trouble falling asleep before 2 a.m. at least 3 times a week. Plus, these other kinds of sleep disorders, insomnia, obstructive sleep apnea, and delayed sleep disorder is kind of folded into that. So this is a big problem, and I mentioned some of the reasons, and these are the reasons you're talking about. They have a lot of responsibilities, like sports and homework. They have social interests. They've got early school start times. Often this is complicated by electronic devices, including their cell phones. It's possibly complicated by stimulants, as I mentioned. Some kids stay up late because it's the only time they don't have their parents nagging over them. And, of course, parents have basically lost control. So I'm going to skip over some of these but to mention the problem of school start schedule. So here's the data about early school schedule. So what happens in the country as a whole, that they have a 65-minute earlier start in 10th grade, and this results in less than half of them even getting 7 hours of sleep. The sleepiness is as bad as the sleepiness of narcolepsy. So when there has been some usually grassroots effort to get school to start later, what they found was that the kids were getting an hour more sleep, but they were getting it in the morning, right? So in other words, they didn't go to bed any earlier, but because they didn't have to get on the bus at that time, there was less daytime sleepiness, increased satisfaction with their sleep, more motivation, better attention, better performance, less self-reported depressed mood, and visits for somatic complaints, as well as being late for school. And look at this data. This one's actually really compelling. One community in Kentucky that changed the school start time decreased the rates of teen car crashes by 16% at the same time that the state average went up by 7.8%. So that means basically a 23% difference in car crashes. And car crashes are in the top 3, usually it's number 3, reason for death in teenagers. So this is really important, and it's worth advocating for it. Not to say that it's so easy to do, right? It's not actually so easy to get that change to happen. So when you can't get the system to change, you may have to just, if the child is actually struggling, they may have to make some accommodations. So maybe they have to not do as much sports. Sorry to hear it. I don't like to advocate less school. They may have to argue for less homework, for example. Even if the school system won't change the start time, maybe they could reduce the homework load, or find out if the kid can drop some elective and have a study hall time instead. So those are real patchwork answers to what is a societal problem. So the other thing to think about is, for some kids, the bus ride is very long, and if they're willing to find another way to get to school, the parent can drive them, they may be able to get an extra half an hour of sleep if they don't have to ride on the bus. So it's something else to think about. I am not a fan of trazodone because of its carryover drowsiness. It's a pretty big gun. So trazodone is one of the medicines that's helpful in kids with PTSD and sleep trouble, like who've been sexually abused or something, and sleep trouble. Right?
And there are other alternatives and that I would use first. The sleep hygiene one that are really important to work on, and getting them up in the morning on the weekends at the same time as the weekdays, that's a big one. But rarely I have used trazodone, and it has some efficacy, and in the kinds of kids you're talking about, I'm really not opposed to it.
So in other words, if you have to, it does help. So it's probably okay, but watch out for daytime drowsiness.
Can I go back to that for a second? So for these kids who are getting to bed at midnight and getting up at 7, so they're averaging 7 hours of sleep a night, is it really the right thing to tell them? Because I don't tell my patients to get up early on the weekends. Like, should we really be telling them to continue that inadequate sleep? I mean, I know what you're saying about the sleep schedule, but...
So that's a really good question.
What about catch-up sleep?
Right. So the answer is catch-up sleep does not work. And here it is right here. So what happens is the catch-up sleep itself further delays the melatonin. So it's a vicious cycle, and getting catch-up sleep dissipates the residual sleep structure. So I do not recommend sleeping in. Now, you can probably manage a 1 hour difference. So most children will tolerate a 1 hour difference in bedtime and wake up time. So, but try to get them to keep it to 1 hour and not more than that.
It's a tough argument, but you need to persist at it, and they're in a hard place.
Right.
And
so
the parents, they feel sorry for them, just like you do.
Right.
They say, oh, my God, they've got to catch up on their sleep. That's what they call it.
They call it catching up, but it's actually not true. It's not a good thing for them.
Causing more of a problem for them.
Right. So that's probably different than what you've been saying. So you may need to, one of the things about this is that we're all in this together with our patients. First of all, because we're not getting enough sleep. That's one way we're in it together. But the other thing is that you really have to negotiate what their priorities are for their life with how much trouble they're having with their sleep. So you may want to have them do an experiment and say, okay, for the next 3 weeks, do it my way. Do it. Don't make your difference more than an hour, and see how you're feeling, and actually you keep a diary of some kind on how you're feeling during the day, how your awareness is during the day, how your focus is during the day, how you're feeling by doing the new system. And you have to give it enough time. 3 weeks is usually enough for that.
They'll argue, they'll say, well, I go to a party on the weekends, and so I stay up a little later. But they can tolerate the exception if their chronobiology is set for time. In fact, when I'm asking about sleep, the most important question I ask is, what time does the kid wake up on the weekend? Because if they say that they have to wake up at 7 and then they wake up at 10, I call that a 3-hour sleep deficit. And just because it's common doesn't mean that it's not a problem for the child, especially those who are inattentive already.
How young a child would you consider treating with medication for their sleep issues?
How young a child? So the younger the child, the less likely I am to use any kind of sleep medicine. For one thing, we don't actually know what these medicines do to young children and their development. Melatonin is a natural substance, but that means we're messing up something going on in their brain. So the other thing about young children is parents should have much more control over their bedtime with young children. And so a lot of the things we've been talking about are older child and teen issues, because for young kids, the parent should be able to set a schedule and get the kid into bed. Now, I used the poison word, didn't I? I used the poison S word, the should word. So I know it's hard, but this is actually a major responsibility of parents to set a structure for their kids' sleep, because look at some of these things that happen with sleep. I'll just run you by a couple of the bad things that happen, okay? So here's what happens. Poor sleep results in a thinner gray matter and prefrontal cortex. Now, you know that prefrontal cortex is where we're getting some of the executive functioning, which is already a problem with teenagers. So we know that less sleep causes poor judgment, poor decision-making, low motivation, poor academic functioning, and trouble with working memory, attention, and inhibition, not things that you want to do to your teenager, right? Also, let me get you a couple more. It has metabolic effects. You know that for each hour of sleep lost, the odds of being obese increase by 80%. Look at this. The odds ratio of overweight increases almost linearly or exponentially with decreasing sleep duration. So if they're getting these degrees of sleep, each one of these brackets of sleep increase the odds of being overweight. In adults, where they've measured insulin, ghrelin, leptin, and cortisol, what they see with sleep loss is insulin resistance and increased sympathetic activity, which is associated with hypertension, of course, as well as increased hunger and decreased satiety when they do eat. It turns out that kids who are sleep restricted consume more calories, exercise less, and tend to eat a diet with a higher percentage of calories from fat. That's what they choose. So even controlling for baseline BMI, if they sleep less, their BMI goes up. And then add to that the fact that children who are already obese are at increased risk of obstructive sleep apnea. In adults nowadays, when they go to the operating room, one of the required things they do is measure the thickness of their neck, because the obstruction that can occur even during anesthesia is really serious based on that kind of thickness. There's a couple other things as well. Having a sleep debt increases injuries and illnesses. And look at this data on teen drivers. 1 in 5 reported poor quality sleep, and 2/3 had daytime sleepiness. So 40% said they were sleepy while driving, and 11% of crashes have sleepiness as the main cause. Actually, my very own cousin's daughter died from falling asleep at the wheel in California and was killed by crashing into a truck that was parked on the side of the road. So I'm passionate about this particular topic. It turns out that sleep debt is as dangerous to driving as being intoxicated while you're driving. It also affects mental health. I think somebody, maybe over there in Molly's camp, was talking about the connection between poor sleep and mental health. And it goes both ways. Mental health problems are associated with poor sleep, but poor sleep also increases the risk of developing depression, predictor of relapse in bipolar disorder, and it increases depressive symptoms even if they're not at the point of actually having depression itself. And sleep debt destabilizes mental disorders as well. Less than 8 hours of sleep is associated with a 3 times higher risk of suicide attempts, and less than 4 hours of sleep with severe suicide attempts that require treatment. So those are really pretty terrible things, and these things are even worse if a person is living in poverty, because often the structure and the sleeping conditions are actually worse for people living in poverty than they are for the general population. So those are some arguments you can use for why it's really worthwhile working on sleep. It also turns out that the younger a child starts having inadequate sleep, the more persistent their sleep problems, and the less the more deficits in executive functioning you see as they get older. So it's very important for parents to work on young child sleep, which can almost always be managed behaviorally. How young a kid were you talking about when you were thinking about medicine?
2 and 3.
2 or 3. Okay, so I would never use sleep medicine on a 2 to 3-year-old. So what I would do is have a good soothing routine. Start bedtime if there's a lot of bedtime resistance, even with a good routine, including a book read to them in their bed. Got to be careful because the parent has to not fall asleep in body contact because that forms a sleep association, and then the kid is up again because they wake up because they're not having that body contact. So you have to wean them off of the sleep association by having the parent read the story but out of body contact, then get out of body contact. If the child is likely to get out of bed, the parent can sit in a chair in the room silently or read a magazine without talking to the kid at all. If the kid tries to get into body contact, the parent will go out of the room and say, I'm not going to touch you. I'm going to go out, close the door, and turn off the light. Now, the kid's going to be really upset if you do that. Then the parent can open the door in about 10 seconds and say, will you stay in your bed if I stay in your room? And they say, oh, yes, I'll stay in my bed. And then the parent can sit in the room and every night move the chair 1 foot closer to the door. So that's how you wean off the sleep associations associated with bedtime itself. And you can do the same thing in the middle of the night if necessary until the child has a new habit. But it's very important if the child comes into the parent's bedroom that they not talk to them, but that they lead them back to their bed as many times as necessary, but do it silently so that there's as little positive reinforcement as possible. Now, I usually combine that plan for putting them back in their bed with what I call one-story, two-story. So every kid should have 1 story before they go to bed, but if they come out in the middle of the night, the next night they only get 1 story, not 2 stories. Did I do it backwards? Oh, I did it backwards. Sorry. Give them 2 stories if they stayed in their bed all night. But if they get out of their bed, the next night they only get 1 story, and the parent should say it full of sympathy and remorse. Oh, tonight you only get 1 story because you came out of your bed, because that reminds them that they should stay in their bed. It's also okay to give them a reward in the morning if they did stay in their bed and didn't call out for the parent. So those are some of the most common ones. How does that match up with your 2 to 3-year-olds? The ones that are really unsafe and that they're going around the house in the middle of the night, that is dangerous, no question about it. And I am not averse to reducing the stuff in their room and putting a lock on the door so that the child can be kept safe. Particularly if the child is rummaging around the house and not looking for comfort from the parents. I do worry about things like bipolar as a possible risk factor for that kid. And certainly ADHD can be the earlier signs of bipolar disorder for later. I'm not saying that you should be making that diagnosis, but I would prefer that the child be kept safe in more mechanical ways. Sometimes putting a sibling in the bedroom with them or even having them sleep in the same room with the parent so they can be supervised are things that you can do. But I really try to avoid medication for the 2 to 3-year-olds. It's really more likely to be important to do structure. And making sure that they have that bedtime story is important for another reason, and that is some of the kids that are wild in the night and wild in the day are actually basically not getting enough positive attention from their parents, and they may be anxious. And so making sure that they have special time, often you would do that in the evening, not something wild, but something fun and calming to do with the parent, can really make a huge difference to that problem. Does that sound like a possibility to you, or are you thinking that you still need to medicate this kid?
No, they're great suggestions.
Okay,
So,
great.
I'm sitting in the same room with Deb, who just asked a question, and I think that I feel like for a lot of our families, I mean, these are great suggestions. These are things that worked with my kids. I'm not optimistic for a lot of our families who are really struggling emotionally and, in terms of socioeconomics, who are juggling 4 or 5 children and have multiple jobs, and they just want the kids to go to bed. It's hard to figure out how to help those families.
Well, yeah, actually, everything we try to do for those struggling those families struggling with socioeconomic stresses and multiple jobs, sometimes you can be creative with those families and talk about maybe getting a teenager in the family to be able to help out, maybe have a teenager sleep in the same room with the young kid, or bringing in a relative. I've actually recommended to a single-parent family where they were really struggling with their kid. I said, you might be able to get a roommate who has another kid of their own who is also a single parent, and you could share the space and share some of the child care responsibilities. And you know what? It actually made a big difference to that family to hear that suggestion, that it really helps an awful lot to have another adult who can help out, and not everybody has one who can do that. But looking to see if there's a relative or a friend or another kind of arrangement that would provide supervision for kids so that they can get enough sleep. I see families, even well-to-do families, where I'm living here in Baltimore, I've got families who are commuting to Washington, D.C., and they take the kid in the car at 4 o'clock in the morning and drop them off at a daycare to get the rest of their night's sleep. Well, what do you think about that? How well does that work? It doesn't. It doesn't work because the kid's sleep cycle has been fractured by getting them up to get them in the car at 4 o'clock in the morning. So that people need to understand that finding some kind of strategy that will help the child sleep helps everything about the way that child functions during the day. So I'm sympathetic, but sometimes if you make suggestions that are radical like that, they'll come up with something that maybe is not quite so radical, but that might work. Like maybe their adult sister living down the street would be willing to come and stay for the night on the nights when the person's working a long shift and the kids aren't getting enough sleep, something like that.
Yeah, they're often stressed and they can't see beyond the immediate being fatigued and stressed that evening. They'll know that they're getting themselves into a cycle where it's impacting on their sleep and stress. So if you can get them to do something for 5 days, the truth is, to change a sleep cycle, it can make a big difference in family functioning. Even in the sleep physiology goes across all these cultural issues. And there's some actually more well-to-do parents that have trouble with some of the things that Dr. Howard was talking about. I like to talk to them initially about giving the kid a prerogative of opening the door or closing the door, having a nightlight on or off, because they want to help them. They have an idea that they want to keep their kids safe, and that's why they are sleeping right next to them. But the kid doesn't care about those prerogatives until that moment, as Barbara said, when they're going to close the door. And when I do that, by the way, no parent ever had to close the door. They just start closing the door, and the kid comes to quick attention and screams, and they get the idea that there's structure and limits, and that can be a powerful thing if the parent knows. We're just going to do it for a week. That'll make a big difference.
I actually have two more things I'd like to mention that can be very helpful. One of them is bringing another kid into the bed. So, in America, we've got this strange idea that people should sleep in their own bed. Frankly, that's not true around the world. People don't sleep alone around the world. It's more natural to sleep with someone else. And for some, particularly young children, having a sibling share a bed can make a huge difference in getting them to be able to have a good night's sleep. So offer that up. Sometimes a dog or cat will work, but the dogs and cats are unreliable about staying all night. So sometimes they help with letting the kid go to sleep, but they're not always very good companions. The other thing that we don't want to miss talking about is white noise generators. So I told you it's good not to fall asleep to music, but white noise is an excellent way to fall asleep. And there are cheap white noise generators. You can get them at Walmart for about $10. There are actually apps on your phone. The reason I wouldn't recommend that is because the kid then takes the phone and does something else with it despite listening to the app. But the noise of like that kind of noise is very good for gait stabilization. And because it's a constant noise for the whole night, it does not cause a sleep association in the same way that things that are more intermittent are. The other thing about white noise generators, particularly in poverty situations, is that one of the problems in poverty is noise levels. Look at that. It's even on my slide. So they're living in places where there's a lot of noise going on, and the noise is disturbing. Sometimes the noise is scary. You know, there might be gunshots or sirens or stuff like that going on. So putting a white noise generator in the bedroom can make a really big difference also. Just mentioned that I've only cured ADHD, I think, twice in my whole life. And do you know how I did it? I had the child get their tonsils and adenoids out. And when their obstructive sleep apnea was cured, they were more alert during the day, and they no longer had ADHD symptoms. So please don't forget about this. Obstructive sleep apnea is increasing because of the increased rates of obesity. Unfortunately, tonsillectomy doesn't work quite as well in obesity, but probably should still be done if there's obstructive sleep apnea. And CPAP is something children can tolerate if necessary. They can learn how to do it. But that's a complication that is really important to recognize in terms of you're having the bad sleep effects, even if the kid is spending enough hours in the bed. Sometimes children with obstructive sleep apnea are also frightened of going to sleep, and the parent doesn't know why, and it's because the child feels like they're strangling in the night. This can also be true for restless leg syndrome. Now, restless leg syndrome, which I don't think I've got a slide on here. I don't think I do. But it's something for you to know about because restless leg syndrome is often treatable with iron therapy. There's some recent articles on restless legs that are important to know about because the children may have what they describe as pain in their arms or their legs. It's basically restless limbs syndrome, not restless leg syndrome. And it can be very disturbing to sleep and cause a child to not get good quality sleep and to be afraid of sleep.